All right. Thank you for the invitation to present. This has been a great meeting so far. I am here to talk about a case that I did endovascular components that I think surgery may have been the better option. I find it funny that they asked the surgeon to come up and present their complication, so I will do so. I feel like I'm back in fellowship M&M. But when I got this subject, there's certainly plenty of complications you get when you do big aortoiliac occlusions. The typical ones being rupture and early reocclusion. And so I went in another direction with this talk because there's other talks on ruptures and how to bail yourself out and on the patency rates overall. And so it's an interesting case. It's one that took a lot of forethought, and I think we could have went a bunch of different ways. But it's a guy who came in early 60s, active smoker, no interest in quitting, but half a pack per day. He was sent for left leg rest pain. He had had claudication for about 5 years, and this had progressed to the point where it was kind of waking him up from sleep. They had gotten a duplex at the outside facility that showed an occluded left external iliac with reconstitution at the common femoral, but the femoral is very diseased, as you can see here. In conjunction with this, you'll notice he has a suprarenal aneurysm, biggest measured 5.3 centimeters in diameter. But the left external's out, the right external's diseased. You can see in both common femorals have a component, but the left's certainly greater than the right. Along with that, there was multiple, there was also conjunctive bilateral common iliac stenoses that were moderate. His history, if you notice, he didn't have a left kidney there, and that saccular aneurysm out to the side is likely at the site where they took his artery. He had donated at 22 and had a GFR now around 50, 55. He had had 2 coronary stents placed for an acute MI at age 42, so certainly not the healthiest specimen out there, but had no angina, although didn't really walk far enough because of his severe claudication to do this. He actually saw my partner and decided to do this in a staged fashion, and so the first stage was a left femoral endarterectomy, recanalization of that left external iliac, stented it with a Viabond 7 millimeter, and then bilateral common iliac stents. There was still a remaining stenosis at the junction of the, or at the iliac bifurcation, and so he bridged that junction with a uncovered self-expanding stent because wanted to keep the hypogastric in circulation given the fact that he needed a complex fenestrated repair. So here he is up and over, and you can see the clamp at the site of the endarterectomy, which proceeded first. So they got through, snared a pigtail up, and then intervened. At the end, the left looked pretty good. Again, the clamp's still there, but saw him back after he was discharged on post-op day 2, and his claudication was completely resolved. He said he could walk as far as he wanted. And his groin incision had well healed. They discussed the aneurysm repair at 5.3. Ongoing surveillance was offered, but he was retiring and moving out into the middle of nowhere. If you know Minnesota at all, they were moving up to the Boundary Waters area, and there you don't even get cell phone coverage. So he had significant concerns if something should happen, which at 5.3 I think is reasonable. So planning CT was done for TAVR. A fenestrated repair. And you can see here, I'm just showing this to show that the iliacs are patent. But on the left side, watch for the end of the stent. I think that right there, that little blip was a clamp injury. And so the plan was to just fix that at the time, kind of dilate, get it through, and then expand that stent. And so proceeded with the aortic repair. We had to wait 2 months for the Z-Fen device. And then we ordered it with fenestrations to the celiac SMA and then back-tabled in the right renal. Upon placement, we pre-cannulated pretty easily through the right side and then had problems with the left iliac device advancement. Sometimes when you resheath these Z-Fens after back-tabling, you get almost a little lip in the transition zone. And so with turning the device, we were able to get it up. But once we had it up and we were orienting, all of a sudden we noticed, hey, there's something a little funky hanging around on the end of that sheath, and I don't know if you can see there's the magnified view. And that right there is the ICAS stent. And so we said, well, that's not very good. And so took down the sheath hoping it was still attached. It was not still attached. So then we advanced a balloon up and then used this balloon to pull the stent down. You can see there. But upon doing that, we discovered that the self-expanding had followed suit and came up. So this is the Biobon with the self-expanding bridge stent kind of inverted into it. So at that point, first thing we did is a shot to make sure we had no rupture or no problems, especially at the bifurcation. The sheath was up to that point, and we elected not to pull it back at that point and just create endotrash out of these two stents, so pull the wire back and then re-advance the sheath. So you can see the ICAST off to the screen right there and the Viabon off to screen left. Then proceeded with the fenestrated repair. You can see the celiac SMA stents, and then the right renal, you know it's back-tabled because it's all radio-opaque, but all the stents went in quite nicely. Pulled the sheath back, again, shot to confirm we had nothing bad. You can see we lost the hypo, though, after working so hard to preserve it. But so completed repair actually looked quite nice, and especially the distal looked quite fine. On retrospect, there's a little dissection there in the right external. But at that point, he had good pulses at the femoral level. This was quite a marathon of a case, and so we said, great, we got out of Dodge. It's over, it's done. An hour later, called to PACU for calf swelling and pain. I went to see him because my partner was in another case, and you could see from across the room that he had compartment syndrome. It was not at all subtle in any way, shape, or fashion. So emergent fasciotomies to both legs, significant muscle damage seen on the left already, which for a 6-hour case was a little surprising with the abruptness that it manifested. And so he went back and got his right iliac stented, multiple washouts and debridements for both of the fasciotomy site, got the right closed, but the left had too much muscle damage and some deficits, and so we proceeded with the left BKA, and he did get significant rhabdo and required dialysis for a period of time, but was weaned off. So his 1-month follow-up scan, you can see here, is non-contrast, unfortunately. The sac size was minimally decreased, but at a month we didn't expect a lot, and you can see the endo, or the endotrash there within the aneurysm itself. So learning points of this case, I think they bring up a lot of points and very good for discussion, but anytime aortoiliac occlusive disease in conjunction with an aneurysm is not an uncommon problem that we see. And I think it adds a level of complexity, especially when you're considering a suprarenal or a paravisceral aneurysm. And so you really got to take time to pause. Once you're making 1 or 2 allowances to get somebody treated, it's fine. But once you're on to 3, 4, you really got to go back to the drawing board and say, is this just better done open? Or in some kind of hybrid fashion. And patient preference, I think we let it play a role at times, but we can't really let that influence us to the ultimate part. And then go back, think about hybrid options, in this case, conduit or ephemeral cut down, and then thinking ahead, stent sizing. I think that self-expanding stent should have been a little bigger just to allow for that lip that we knew was going to be there. And then timing, maybe doing it just at the time of the actual fenestrated, but that is a huge marathon case turned even longer, so thank you.